Thank you all for taking time today to learn about fetal alcohol spectrum disorder, FASD. My name is Madonna Mooney. I am a co-founder of FASD Maine, a former nurse and teacher, and a sibling of a person who had an FASD. I feel very fortunate today that we have our two speakers, psychologist Dr. Katie Flanagan of the Canada FASD Research Network and Dr. Jackie Pye of the University of Alberta's School and Clinical Child Psychology program. I first learned of our speakers a few years ago when I read their research, particularly on the challenges facing youth and young adults affected by FASD, but they also focused on the value of the strengths and resilience of these individuals and their families. I reached out to Katie last fall, and she and Jackie very generously agreed to do this presentation. I'm going to turn it over to them to introduce themselves.
Hi, everyone. My name is Jackie Pye, as already introduced. Thanks, Madonna. And as she indicated, I'm a professor at the University of Alberta. I'm also a practicing neuropsychologist, and I am the Intervention Network Action Lead for the Canada FASD Research Network. Really excited to be here today and to join Madonna as we have this conversation. Thanks.
Thanks, Jackie. I'm a little late on the unmuting. I couldn't find my button there. Sorry. So I'm Katie Flanagan. So nice to be here chatting about this today. As Madonna mentioned, I'm a psychologist as well. I'm also a research associate with the Canada FASD Research Network. I've been working with the network for a number of years and in the field of FASD for a lot more years. But I recently, as Madonna mentioned, have been focusing a lot more on strengths and resiliencies and ways of supporting well-being. So this is a topic that we're looking at today that I feel particularly passionate about. So it's really nice to be here. And Christelle.
Hi folks, my name is Christelle Thiering, pronounced she, her. I am absolutely thrilled to be here with these incredible folks today to talk about FASD. I first had this brought on my radar after doing a quick community presentation that Madonna was in attendance. And she asked a wonderful question around mental health and FASD, and I had not a clue to the answer to it. And she kindly has taken so much time to help educate me around the co-occurring things that are happening here. And I'm so happy that we have this opportunity to be able to learn more, talk more about this area, because this is something that definitely impacts our young folks in Maine, or folks of all ages really in Maine. And so thank you all for being here.
Thank you very much, Christelle.
So
I wanted to take a moment to do a land acknowledgement because here at CanFASD and elsewhere, we realize and recognize that an important step in reconciliation is the acknowledgement of traditional treaty lands and recognition for the people of the territory. So although we are coming from different places and spaces, we wanted to recognize that we want to recognize the historical significance and contributions of Indigenous peoples and their cultures. And we understand the important role that the Indigenous community plays today and in the future. So today we want to acknowledge that we all live, work, and meet on traditional territories across Canada, the US, and elsewhere, of many First Nations, Métis, Inuit, and other Indigenous peoples whose footsteps have marked these lands for centuries. So with that, I wanted to give just a quick introduction to get us all on the same page around what we're hoping to spend the next 45 minutes or so talking about. We're really hoping to have folks take away 3 core messages after our presentation today. The first core message is that we really want to encourage folks that we need to tune in to what's going on around FASD and mental health. And in doing that, or in order to do that, we want to think about what are we seeing, what systems and what populations are we working with where we might be interacting with folks with FASD, young people with FASD, and may not even be realizing it. So here we want to say that we need to really start paying attention. The second core message is that we need to understand, once we see young people and young adults with FASD, we can start to understand their unique strengths, challenges, and needs in order to better support and impact outcomes and trajectories. So part of doing that is to think about and understand more about what some of the complexities around the disability, both in terms of challenges as well as as strengths and resiliency. So having a really balanced perspective for both ends of the experience. And then finally, with that better understanding of the strengths and needs of folks with FASD, we want to have creative ways and proactive ways of responding and identifying opportunities for support and intervention, because we can really make a difference when we recognize and understand and respond to the needs of folks with FASD that we're working with or who we're supporting. So with that, I will pass it over to Madonna, and she'll give us a nice context for what we're seeing in Maine currently.
Thank you, Katie. So my part today is to share Maine data that will show you that the risk for prenatal alcohol exposure, PAE, and fetal alcohol spectrum disorder, FASD, is high here in Maine. And because our providers and clinicians in Maine are not yet, we're getting there, fully aware of or informed about FASD, we are not really great at diagnosing these children and adults affected by FASD. And therefore, we're not providing early intervention or adequate services across the lifespan. So we find these individuals as children struggling, largely undiagnosed or misdiagnosed, across these systems you can see here. We find them at much higher rates in foster care and special ed and behavioral health services. And older youth and young adults, despite their strengths and abilities, are languishing unsupported, landing in residential care and juvenile justice facilities, and struggling with mental health issues directly related to the lack of diagnosis or support. The good news is that you will learn today to see, as Katie has said, understand and help those with FASD. You will see opportunities across these systems to interrupt or completely prevent these adverse outcomes. These outcomes are not a foregone conclusion, as Katie and Jackie would say, and they will show you why. So next slide. I will start with some straightforward facts. First, it is important to know that FASD is the #1 cause of birth defects and intellectual disabilities in the US. It is 2.5 times as common as autism and more common than all of the common disorders that you see here on this chart combined. Also, the reason alcohol is so damaging to the fetus is because it is a teratogen. This term means it causes birth defects, like thalidomide did in the 60s, or the rubella virus can. We have known for decades that alcohol causes birth defects across all systems of the body and is particularly damaging to the fetal brain. So let's start where it all starts, for the child that is, with prenatal alcohol exposure. You can see here from this latest CDC report that 1 in 7 pregnant adults used alcohol during pregnancy, and 1 in 20, around 5%, binge drank. 10 years ago, the rate was 1 in 10 reported using alcohol, and the binge rate was 3%. Binge drinking is especially damaging because it is a larger dose, a concentrated dose, a longer duration of exposure. Next slide. From that same report, here in Region 1, New England, where we Mainers live, 1 in 6 pregnancies, pregnant adults reported alcohol use. We have the second highest in the country. Next slide. Here in our state of Maine, you can see as a state overall, the rate of alcohol use among pregnant women was 10%, 1 in 10. And that 6 of our 16 counties were 10% or higher, with Cumberland County the highest at 1 in 6, or 16.6%. Maine has on average about 12,000 live births a year, to give you some context. You can also see the demographic here that those more likely to use alcohol in pregnancy are older, higher income, higher education, insurance other than main care, and intended pregnancies. So I hope this data is helping you to better understand why prenatal exposure, alcohol exposure, and FASD are so prevalent. Next slide. Research tells us that certain circumstances and behaviors are red flags for alcohol use in pregnancy. If we drank a lot before, if we binge drank before, used tobacco, any drug or substance use, whether it's opiates or methamphetamine or marijuana, partner violence, partner drinks, again, if we are older and have higher income or higher education. Next slide. Remembering those red flags for alcohol use in pregnancy, excuse me. We also know, among pregnant adults who use drugs and alcohol, sorry, hold on. Thanks. that polysubstance use is the norm. And you can see here in the US, of those pregnant women who used opioids non-medically, over half binge drink and many used cigarettes and marijuana. In a separate study of over 160,000 pregnant women admitted for substance use treatment, they found that alcohol and marijuana were the most common co-exposures. Next slide. So again, remembering those red flags for alcohol use in pregnancy. You can see here in Maine, those adults who were asked about their substance use 3 months before their pregnancies used alcohol, 69%, marijuana, 22%, and any kind of tobacco product, 32%. Next slide. So this is from the CDC website, alcohol use among childbearing aged women. And you can see here that Maine is among the highest in the country at 62.6%. It's also important to remember that in Maine, about 40% of pregnancies are unplanned. Next slide. And here we have binge drinking among Maine women of childbearing age at 35%. We're not the highest, but we really don't want any binge drinking. My contact at the CDC calculated that at this rate of 35% at the time of this survey in 2019, that 46,000 Maine women of childbearing age were binge drinking. Next slide. Remembering that polysubstance use is the norm, it is likely that these substance-exposed newborns are at high risk for prenatal alcohol exposure. So every year since 2013, we have had 800 to 1,000 until just last year reported substance exposed. And remember that here in Maine, we do not have a system yet for tracking children with prenatal alcohol exposure. So imagine if we had been flagging the charts of these children for the past 10 years so that we could follow them and screen them for FASD. Next slide. Okay, I think we have established the risk for prenatal alcohol exposure in Maine. So now we're going to look at data across these systems where we are likely to find higher rates of FASD. And keep in mind that it is very unlikely that any provider in these systems has diagnosed FASD in these children or adults. And think about what that means for children and their families, an unrecognized disability and an unsupported disability. So we're going to start with the next slide with foster care. We know that through research, that FASD is prevalent in foster care. A child with FASD is 17 to 19 times more likely to be in the child welfare system than someone without an FASD. In this profile from the Washington State FASD Clinic, of the first 1,400 patients evaluated for FASD, 70% were no longer in the care of their birth parents and had on average 3 out-of-home placements. The rate of FAS, which is just one diagnosis on the spectrum of FASD, was 10 times the general population for foster children. And so also think about the adverse childhood events that are adding up here. Next slide. So here in Maine, we currently have over 2,400 children in foster care. And according to the latest data, 50% of child removals were due to parental substance use. About a quarter of the children in foster care have 2 or more home placements. And in the report from 2019, which is the last report that expressed this data, 1 in 5 infants entered foster care due to a substance-exposed infant report. Again, you can see the adverse childhood experiences. The ACEs are adding up here. Next slide. In this report, in those child removals that involve substance use, they broke it down by substance, county, maternal, or paternal use. And you can see here that across the state, maternal alcohol use was a factor. Sorry, guys, hold on. Thanks. Was a factor in removal. And of course, this increases the risk for FASD. Androscoggin County at 45%. That year, there were 143 removals. Hancock County at 86%, 54 children were removed. Next slide. For the past 10 years, around 50% of all child removals involves substance use. Next slide. And the number of child removals in the last 10 years range from 800 to 1,200 a year, every year. And again, you can see how FASD is likely prevalent here in Maine. Next slide. Another system in which we find the higher rates of children with FASD, undiagnosed FASD, is special education. And here in Maine, we have 30,000 students in special ed, 20% of our student population. Although awareness of FASD in our school systems is also slowly improving here in Maine, for the most part, school professionals in Maine are not trained to evaluate students for FASD. A child with FASD may confound his teachers because he may have an average or low average IQ, yet he has impaired attention, executive function, processing speed, memory, and adaptive IQ. So despite average IQ, many children with FASD do not have the capacity to apply their intelligence to everyday demands of the classroom unless they get support. Next slide. In Maine, as in all states in the US, there are 13 categories in special ed under which a child may qualify for services. FASD is not a named condition under any of these categories. So a child with FASD does not automatically qualify for special ed. They may be eligible, but not on the basis of the brain injury of FASD. They often qualify under another diagnosis, for example, ADHD or the category specific learning disability. But these diagnoses do not begin to address the complex needs of children with an FASD. Slower processing speed, dysmaturity, these children act much younger than their peers, and difficulty with self-regulation and understanding cause and effect. So what I have included here are those special ed categories whose numbers are large enough to actually be seen on a pie chart. And what I want you to consider are the high numbers in those categories where we often find children with undiagnosed FASD. For example, specific learning disability. Many children, there's a high rate of auditory processing disorder, math disorder, and dysgraphia, difficulty handwriting, among children with FASD. And you can see over 9,000 children in that one category. Also, other health impairment. There's over 7,000 children in that category, and it's predominantly children with ADHD, another very common diagnosis for children with FASD. And even emotional disturbance, as it is defined under special ed, as an inability to build or maintain relationships with peers and teachers. Children with FASD, they are much less mature than their peers, and finding and keeping friends is a painful challenge for these children. Research shows that in the US, 61% of children with FASD have disrupted school experiences, higher rates of academic suspension, expulsion, and dropping out. And here in Maine, over 36% of students receiving special ed have had one or more out of school suspension. That's over 2,600 children. Again, when we are not identifying youth with FASD, we cannot help them. Next slide. Another system in which we find higher rates of FASD is juvenile justice. And here in Maine, we have the Long Creek Youth Development Center, which is predominantly male youth, 87%, that are held here. And we all know here in Maine that Long Creek has had a number of investigations over the years due to concerns over treatment of the youth held there. And there's been a lot of debate on whether to keep the center open. I am including data from these investigations just to illustrate that here in Maine, there are incarcerated youth with undiagnosed FASD. And to that point, I would like to read a brief excerpt from recommendations made in a report from 2020 by the Center for Children's Law and Policy. They write, FASD's effects on the brain can result in cognitive or behavioral deficits. These deficits may include learning disabilities, hyperactivity, attention deficits, and poor social skills. These and other problems associated with FASD may increase the chance that a person will break the law. Additionally, individuals with FASD typically are impulsive and have trouble foreseeing the consequences of their actions. Many are very susceptible to peer pressure and can be easily led. Their judgment is often poor. These effects are particularly problematic for youth who are incarcerated, since they may lead to misbehavior, disruption, discipline, and longer incarceration. Thus, in addition to screening youth for traumatic brain injury, youth should also be screened for FASD at all entry points into the behavioral health and juvenile justice systems. Their own report tells us that youth with FASD are found at higher rates among this population. And the only information I want to add on these slides, as you can see here, there's much higher child welfare involvement with these children, 65% here. 75% total have received some kind of special ed services at the time of their commitment. Next slide. 69% received behavioral health services the year prior to commitment. Next slide. And we see here that over 85% of these youth were receiving outpatient services. Over 50% had a residential stay. Youth with FASD are at greater risk for mental health problems and behavioral disorders, due not in small part to the lack of early diagnosis and intervention for their disability. As Katie and Jackie have said, it is not a foregone conclusion that these secondary disabilities occur. Next slide. Finally, almost 85% of youth, arriving at Long Creek had 3 or more mental health diagnoses at commitment. Youth with FASD have high rates of these diagnoses here: ADHD, PTSD, depressive and anxiety disorder, conduct disorder, and substance use. Again, an accurate diagnosis and intervention could stem the tide of youth incarceration. We're going to end the next slide with the Maine Integrated Youth Health Survey of 2021. This is just to give you an idea of the state of youth in Maine in general at this point. They were asked, during the past 12 months, did you ever feel so sad or hopeless almost every day for 2 weeks or more in a row that you stopped doing some usual activities? We can see here, almost 36% of something like the 50 or 55,000 children asked this question reported yes, almost 20,000 children. Next slide. This was, these students were asked about ACEs, and you can see here almost a quarter of these kids, over almost 12,000, reported 4 or more ACEs. And children with FASD, FASD is associated with higher ACE scores. So next slide. I hope you can see that FASD is rarely diagnosed, but likely prevalent here in Maine, especially across these systems. So this information actually gives me hope, because the more we all know about FASD, the more we will find these children and youth, and the more we can help these children and families. I'm going to now pass it on to Katie and Jackie. Thank you.
Thank you so much, Madonna. That's, I think, provides some really helpful and compelling information and contextual evidence, I suppose, around the systems where we can assume that we are interacting with young people with FASD. And although, as Madonna says, there's very little in the way of formal assessment and diagnostic services in Maine, we can, based on the literature and in other populations, we can find a lot of overlap in these systems where we can assume that we are for sure encountering young people with FASD. So to begin my section, I wanted to spend a few minutes talking, actually before I wanted to say that we built in a few minutes at the end for questions. So I don't have the multitasking skills to open up the questions in the chat, but we do have some time reserved at the end. So we will be reading your questions and your comments. We saved about 10 minutes at the end. So fear not, we will read what you're saying in the chat. I wanted to start off with a simple definition of FASD, because I think it's just helpful in terms of language and terminology to start at the same place and understand what we're all talking about. So at least in Canada, not everywhere, but in Canada, FASD is an actual diagnostic term. And the diagnostic term is what describes the impacts that prenatal alcohol exposure has on a person's brain and body. FASD is associated with multiple challenges in daily living and cognitive and behavioral functioning. And many or most folks with FASD will need significant support across all areas of their life in different domains. But importantly, we always need to remember that although FASD is characterized by significant difficulties, people with FASD also have significant strengths, and everybody with FASD is unique. So we never want to take a one-size-fits-all approach to understanding or supporting people with FASD. As Madonna mentioned, stats are important. Prevalence is important. So to give us a kind of an idea of how many people in our communities and societies we're talking about, researchers conservatively estimate that 4 to 5% of the population in Western countries have FASD. But that said, as Madonna pointed out, not in Maine specifically, but in other populations, researchers have noted that there are subpopulations of our communities that do show higher rates of FASD. So one example, as Madonna mentioned, is child welfare. So compared to the general prevalence rates of 4 to 5%, it's about double in child welfare settings. So about 11% of kids who are involved in the child welfare system are likely to have FASD. Another particularly vulnerable system or population is youth and adults who are involved in justice and correctional systems. So in one study in Australia, they found that 36% of youth in a detention center had FASD. So almost a third of that youth population. So this is just to say that although we don't have prevalent stats necessarily for Maine, we do have prevalent stats from other settings that we can kind of extrapolate and put together and kind of not encourage, but they kind of validate our assumptions that in a lot of these systems we will be interacting with young people who have FASD. So as we all know, FASD is a brain-based disability, a neurodevelopmental disability. These are the 10 common domains of brain function that we look at when we're thinking about the impacts of prenatal alcohol exposure. And in fact, in Canada, these are the 10 domains of brain function that are assessed in order to diagnose a person with FASD. So although these are the most commonly impacted areas, it's important to remember that FASD is a spectrum disorder. So that means that not everyone with FASD will experience all 10 of these. In fact, for a diagnosis in Canada, you need significant deficits in 3 of these areas. So each person with FASD is unique and has unique needs that can change across the lifespan, can change by individual, and they also have significant strengths that need to be considered as well. So in addition to some of the more cognitive or neurobehavioral deficits that we see coming from prenatal alcohol exposure, we also know that prenatal alcohol exposure impacts the brain's sensitivity to stress. Jackie is the expert in this area, so I will not pretend to know as much as she does, but I can tell you that prenatal alcohol exposure does sensitize the stress system in our brains. And so there is some interesting research that shows that when we combine this sensitized stress response system that's due to prenatal alcohol exposure, and we compound environmental adversity like trauma and difficulties in daily living postnatally, that really, really increases vulnerability and can increase risk for mental health, development of mental health challenges later in life as well. So some examples of the early adversity and lifelong adversity that children and young people with FASD experience. Madonna has alluded to some of these already, but often kids with FASD will experience caregiving disruptions and live in multiple caregiving environments, be involved in the child welfare system, be exposed to many different kinds of trauma, many different kinds of abuse and neglect. In one study that we published a year or so ago, we looked at adverse childhood experiences in a group of children and adolescents in Alberta, where Jackie and I are. And we found that with age, the total number of ACEs that children and adolescents with FASD experience increased. And it also, the total number of ACEs increased with the number of placements that children and adolescents lived in. And it also was significantly correlated with higher mental health needs. So we can see that the more significant adversity that a person experiences in their early life can really contribute to and compound the brain-based vulnerabilities that result from prenatal alcohol exposure. There's also been some research recently, well, actually for years, there's been some research looking at outcomes for folks with FASD. And recently we published a Canadian study or a Canadian data around difficulties in daily living for adolescents, young adults, and adults with prenatal alcohol exposure who were assessed for FASD. And these are some of the difficulties that were most commonly reported in this group of, I think it was, I want to say 1,200 or so people. So it was a very large sample of people with prenatal alcohol exposure. And these are some of the difficulties that they were experiencing. So I wanted to highlight too that, as Madonna has said, these are not foregone conclusions, but they are examples of outcomes that can arise when we don't do a good job of identifying, tuning in, and understanding the needs and responding adequately and appropriately to the needs of people with FASD. Very importantly, we also know from research that there are protective factors that can protect against some of these outcomes. So Anne Streiskuth and her colleagues in Washington, she's a bit of a legend in the FASD world, they reported in the early 2000s that there are some significant protective factors, particularly around the home environment. So children who lived in high quality, nurturing, and stable home environments were likely to have better outcomes. Also, as Madonna has mentioned too, the earlier we can identify and diagnose a child with FASD, the better their outcomes will be. And so we know that based on this research that these are some protective factors against the negative outcomes that can arise when the needs of people with FASD are not addressed. The main focus of why we're here today is mental health needs. And so I wanted to spend a minute or two diving in a little bit more to the data around specific mental health needs in FASD. We know from research that about 90 to 95% of people with FASD have co-occurring mental health needs. And very recent data that we pulled in a project from the National FASD database in Canada, there's some data here on some of the most common types of co-occurring mental health needs. And so interestingly, the mental health needs that Madonna pointed out in the Long Creek Youth reports, there's a lot of overlap here with the most common mental health co-occurring needs that people with prenatal alcohol exposure experience in Canada. So this is to say that all these numbers are coming together to really give us a picture of some of the common needs that we need to be thinking about. We also published a study on, actually we had a number of studies on suicidality in the last couple of years, and we looked at the rates of suicidality across the lifespan. Here we operationalize suicidality as suicidal thoughts or behavior at any point in an individual's life. So in the whole sample of 800 people with prenatal alcohol exposure, we found that 26 or 27% were reported to experience suicidality, but the highest rates were seen in adolescents and young adults. So this also aligns with research in general populations where youth and young adults do experience higher rates of suicidality, but the actual numbers are considerably higher in the FASD population than in the general population. And even in these early school-aged years, 12% prevalence of suicidal thoughts and behaviors, which is just telling us that this is a significant issue. Mental health is a significant priority that really is calling for early intervention and proactive responses. Some of the most significant factors that are associated with suicidality were substance use challenges, experiences of trauma, and affect dysregulation, which is a fancy way of saying depression and anxiety. So these are some really common needs in folks with FASD that significantly increase the likelihood of experiencing suicidality. So in another really meaningful and impactful arm of this research, we talked to caregivers about their experiences with their youth and young adults around suicidality and mental health. And they gave us some really interesting and insightful information around the contexts that might contribute to suicidality and mental health challenges for youth and young adults. Some of the main themes that they were pointing out that their youth or children and youth experienced were their child's responses to frustration and conflict often led to feelings of suicidal thoughts and behaviors. Also a sense of shame, not fitting in, and a sense of hopelessness were all kind of the themes that we found from conversations with caregivers around what might be contributing or what might be associated with mental health need and suicidality. And caregivers also pointed out a number of areas of strength and resiliency that were also really important to highlight. So caregivers mentioned strategies that help to support their children and youth who are struggling. So I'm almost finished and I will almost pass it off to Jackie, but before I do that, I just wanted to say that when we're thinking about FASD, I have spent a lot of time talking about mental health disorders and disabilities, diagnoses and labels, but we don't just want to think about mental health as an absence of these labels. We want to think about mental health not only as, of course, an absence of these labels, but also ways, holistic ways that we can understand a person and comprehensively meet the needs of a person to increase well-being and happiness. So not only the absence of disorder, but also what we can do to leverage strengths and resiliencies in order for folks with FASD to experience happiness and well-being. So I'm going to end with a quote from a young person with FASD who participated in one of our studies recently. She's a 28-year-old, and she said, I want people to know that people like me exist and we need support and understanding. I'm creative and I love to care about others a lot. I thrive well with positive environments and happy things to keep me looking forward to the future. So that is, I think, a nice segue to Jackie, who is going to tell us about some of the opportunities that we might recognize for supporting folks with FASD.
Awesome. Thank you so much, Katie. Thank you, Madonna. I think that you guys have done such a spectacular job of highlighting the urgency of this issue and the urgency of recognizing and understanding individuals with FASD. And as both, Katie, you guys really did set me up great, right? They know my soapboxes apparently, because, it is urgent that we pay attention, that we tune in, that we are able to identify folks with FASD, because it is not a foregone conclusion. Madonna said that a few times. As Katie emphasized, there are strengths, there are resiliencies to leverage, and there are alternative pathways forward for folks with FASD. We're not intending to make it sound like an easy story, and we're not trying to say, oh, just no, and then away we go. This does require concerted and collective effort. But when we work together and pull together, we really can begin to identify the opportunities for support. And as we do that, as Katie just kind of mentioned, we can start thinking not just about how do we mitigate problems, how do we solve the issues that are presenting, but how do we actually imagine these healthy, well pathways for individuals that are really deserving, as all of us are, of experiencing purpose and meaning in their lives. This is where we're going. We're not looking to solve problems. We're looking to support healthy development and this pursuit of wellness and purpose and meaning that we all share. So as we get started, Katie, are you the master of the slides here? Is that you? Yeah, all right. This is really great. They don't even let me control my slides, which is probably smart, because if I start waxing poetic, she could just kind of keep me flipping along, which is really a good cue for me that, oh, come on, Jackie, watch your time. They put me in, these time blocks, and it's really important, because any of you who know me know that I get a little excited about this topic. So the first thing I want to highlight as we talk about opportunities for support is exactly the kind of messaging I'm just sharing, and extending on what Katie and Madonna have already said. And that is that individuals with FASD have many strengths and can be highly resilient. So although they may experience these elevated vulnerabilities that we're talking about, exposure to adversities that are of concern, there's also really good evidence that they can experience resiliency, and that when we leverage the opportunities available within our communities and within the individual with FASD, we create the best opportunity to work towards this wellness. Some of our recent publications, we've started to highlight some of those resiliency factors. What are those nuggets that help us promote resiliency even in the face of adversity? And we've also, and Katie led us through the story of balancing these strengths so that we start to get a more balanced understanding of FASD, so that we can start to strive towards wellness, recognizing that inherent to every individual with FASD is strengths, not just difficulties. They're not a problem to be solved. They're people to be nourished, and they're people to be supported. And that's the balance, and that's the shift that we really want to encourage as we think about opportunities. On the next slide, you'll see that we've just listed some of the strengths that have been identified in the research that associate with individuals with FASD. They have strong self-awareness. And by the way, folks, that is not any small deal. Any of you know folks that don't have strong self-awareness, where, they say one thing and do another? I tell you, there's a lot of us out there. And so these are big deals. Being receptive to support, being willing to say, yeah, thanks, I could use the help. Again, these are significant and noteworthy strengths that if many of us look in the mirror, we might go, ooh, I could improve on that. Capacity for human connection. I'm going to talk more about that in a moment, but this is one that's reported consistently. The ability to persevere through challenges. Keep trying, keep trying. This is a really critical one. And it's actually one of those strengths that I think flies in the face of sometimes the misunderstandings associated with FASD, in which when we find that, Madonna talked about, sometimes we see those higher intellectual functioning, but folks that can't necessarily action those abilities, we're quick to assume people that don't try or don't care. When we start to deeply understand the population and gain a balanced approach, we begin to recognize that just the opposite. This is a highly connected and relational group of folks who actually persevere through challenges and care a lot about having meaning and connection. They hope for their future. They want to be part of their future. And so it's a matter of us understanding the unique brain when we try to create opportunities for them to realize these strengths and appreciate them and not be misunderstood by us who are kind of on the outside looking in. On the next slide, I just want to highlight something that an individual with FASD said, because as Katie shared quotes, I like to share quotes because sometimes I feel like it's so much better said when it's not me. I have a good heart and sometimes do struggle with basic daily life, but I never give up. I don't stop believing at all, even when everything bad is thrown at me. So this to me epitomizes exactly what we're talking about. Here's somebody who actually genuinely believes both in themselves and their capacity to contribute, and even maybe the world around them. So let's step into that. Let's step into that and start walking with folks. So how do we do it? I'm going to name 4 sort of levels that I think we could think about intervention. You're getting it in the brief soundbite version here, guys. So if you hear something you really like, we can ask questions or you can follow up with me later, because I just want to highlight the scope of possibility in terms of interventions available. We can do intervention at an individual level. We've demonstrated, and other researchers have found that when you work with individuals with FASD, they are keen to learn, and within their own unique abilities and capacities can build their skills. To what level, to what degree, that varies. As Katie said, everybody's unique, just like the rest of us. But this does not mean that skills can't be built and they can't be developed. They can, totally. We can build social skills and social interactions and create more healthy patterns with peers. We can create space through an understanding of FASD for growth in any number of cognitive areas. For example, when we have an understanding of FASD, we see growth in things like individual math skills and their ability to kind of problem solve through things like those academic skills that can be difficult. Growth and improvement at that individual level is possible. When we understand that there are brain-based differences affecting their stress response system, Katie talked earlier about that regulation and that sensitivity, we can actually help kiddos understand their own bodies. Young adults and adults start to understand their own bodies and get a little bit better at regulating those emotions. They can improve. It takes time. It takes understanding. There's lots of words called understanding that we, nest in all of our interventions. But when we work together, and when we listen carefully to what folks with FASD are telling us, we can understand their perspectives, and we can co-create and generate strategies that actually help them to initiate an intervention for themselves that supports improved management of these abilities. So that's the individual level. We can also work at a relational level. Like I've noted before, connection is something that is a real strength for individuals with FASD. Strength in relational factors is actually a big resiliency factor for individuals with FASD. When relationships are solid, when they have a good community of support, outcomes are improved. Big surprise, right? Kind of applies to all of us, right? We do well when we're well supported in networks that understand us and help us to find well-suited activities and endeavors. That's no different for folks with FASD. And in particular, establishing a familial or family-based ability where they can have an ongoing, stable, routine, and systematic support around them, we see really great outcomes. One of the programs that I want to highlight and kind of do a shout out for right now is Families Moving Forward. This is a program developed by Heather Carmichael Olson and is currently being implemented by Christy Petrenko right in your neck of the woods. I think that's going on in Maine as well. Is that right, Madonna? Yeah, I've seen a nod. So yay, you guys get the amazing ability to work with Christy Petrenko and her team who work closely with Heather, and are doing exactly these kinds of support, relational supports that say, how do we support the people supporting the individuals with FASD so that we can be stable, so that we as caregivers can manage our own emotions and really meet the folks that we're taking care of the best we can, because when that environment and relationship are solid, that creates the environment that is healthiest and most nurturing for individuals with FASD. And there are lots of relational sources of support and interventions that are out there. If you're interested, let me know and I can flip stuff your way, folks. The next level is at a community level. So this is the next level up. So we start with the individual, we get to the relationships around them, and we get to the community. And this is where we're talking about systems of support. We're starting to think about clinicians or teachers or physicians who might be working with folks with FASD. At this level, we understand that good education and training is critical. We need to be able to respond in a shared manner. We have to have a shared understanding. We have to be integrated in the way our systems are delivered. Our clinicians, our schools, our doctors, everybody has to be kind of talking the same talk and going in the same direction. Otherwise, it gets really tricky and things get pulled in different directions. How do we do that? Sometimes education helps. It helps us get us on the same page. Sometimes we have mechanisms or tools, resources that can help us to get on the same page and navigate the journey together. For example, Dr. Mansfield Mella has produced a medication algorithm, which is kind of like a pathway tool to help docs kind of navigate the process of making decisions around medication for kiddos with FASD, and takes into consideration all the unique aspects of FASD. Other tools we have a Towards Healthy Outcomes framework, which is an intervention framework that says, hey, these are all the things that you might want to be thinking about as we support somebody across the lifespan towards wellness and healthy outcomes, and how we might work in a goal-oriented way together. The Canada FASD Research Network also provides things like training programs for teachers, training programs for folks working in the justice system that help establish a shared language and shared goal setting practices so that we can kind of come together and be on the same page. So just a few things that we could be doing at a community level. Finally, at a level of society, if we step one step bigger, that's everyone. That's all of us. It doesn't matter what place or space you live in, but it's about how we think about each other, how we think about folks with FASD, and move away from stigmatizing, oh, well, they're just gonna, be using drugs, or how do we just keep them from going to jail? That's actually really stigmatizing. And although those are important goals, what we're really interested in is wellness, and saying, how do we promote success and healthy living? How do we work towards wellness? It doesn't mean we ignore the need to address our concerns. That's embedded in our pursuit of wellness. And that's how we move away from stigma towards just seeing individuals with FASD as human beings first. FASD is part of who they are, but they are human beings first. This is where we start to think about equitable access to service. Individuals with FASD deserve to be recognized and deserve to have the level of service provided to them that is necessary for their unique needs in order to pursue that pathway towards wellness. Appreciating the impact of social determinants of health, and saying from an early age, how do we promote wellness, stability in lives, and alternative pathways that will recognize these kiddos early and get these wraparound supports to them. And sometimes doing all of these things require universal FASD strategies and policies that bring us together. I know in Maine, just like in Canada, we're all working towards elevated understanding and gradually towards the idea of some shared strategies and policies that will hopefully bring us together into an integrated approach. You want to go to that next slide. And this kind of takes us to the space where I envision that when we work towards these healthy outcomes and really leveraging opportunities for individuals with FASD, we want to consider all 4 levels of intersection, where we're saying, how do we support growth in the individual? Because they need to be part of their own story and their own lives, because they are an active contributor. So we're engaging individuals. Relationally, we're engaging their intimate communities, their families, their support people, those natural systems of support that we all need. We're then working with those larger communities to support the professionals who might also come around and provide that integrated and specialized systems of support, all within a society that increasingly can be accepting and appreciative of the many strengths that individuals with FASD have to offer. So that's the soundbite. And here's just some more quotes, because we're going to put it into the voices of caregivers. Like I said earlier, the quotes always say it better. I'm excited about the growing awareness around FASD and hopeful that my kids will live a full life. We have a big and great social support network. You know, imagine if we could all say something like that. What a powerful statement. I love this last one, maybe the most. Not that I have to pick favorites, but I did. I love her fiercely, and I will always be in her corner. We both have a great sense of humor, and I trust that, and our deep love will carry us through whatever lies ahead. If we could all be loved and have advocates like this in our lives. So thanks, Katie. So I just will, you can click on and I will shift back to you on that note of opportunity and encourage folks that thinking about those opportunities that are available, being creative and embracing the potential and possibility that those folks with FASD in your lives have, I think is the way forward. And I think together we can really get there. So I look forward to hearing from you all. Take it away, Katie, and take us home.
Thank you, Jackie. I think that really resonated with me on the last slide, the caregiver quotes. It just really highlights how the relational pieces, right? The importance of relational, both for the individual with FASD and also for their family support systems to have those close connections and those close supports. So anyway, this is my side thought, but to bring us back to our core messages that I wanted to start off with, and I want to remind folks that this is what we're trying to drive home today, our three takeaways. So we really need to tune in to the systems we're working in, the populations we're working with, and pay attention to who might have FASD and who might benefit from FASD informed supports and services. Invest time in understanding both the challenges and the strengths of the individuals, youth, adults with FASD that we're working with, and then being really creative in our responses. And I think Jackie gave us a really lovely list of places where we can start to be creative with the ways that we respond to the needs of folks with FASD. So again, just to be really repetitive and make sure everybody remembers what we're trying to say, we need to pay attention. We need to consider the whole person, as Jackie said, human first, and recognize that the many opportunities that we have to respond and support mental health and well-being. This is just a quick summary pretty much of what Jackie has already said. I just wanted to have it all in one place, action items for us to think about going forward. These are some of the ways that we can, or some of the areas where we can focus and emphasize in our work in the FASD community. And we also wanted to leave with you with a list of resources that I will not go through individually. I just wanted to keep them here in the slides, which we will share for folks just as some both local and resources from elsewhere as well for folks to click through. And finally, kind of exciting and very timely and relevant to the topic today, we are at CanFASD in the process of developing a toolkit for mental health professionals. So it's not yet released, but it will be released soon. And the idea is sort of a training module or a toolkit for folks who work in mental health settings with people with FASD to equip them with more skills and more knowledge to support healthier outcomes. Okay, could it possibly be that we are done? Oh, let me click forward. There we go. There's our email address. So folks, if anybody wants to reach out or has questions that we didn't have time to discuss today, I am just so very proud of us for finishing in time. And
I'm very grateful to you both. I mean, this was so powerful for me to hear it so succinctly stated, you know, point by point, exactly what we can do, exactly what it looks like. I had to do the dirty job of sharing all the kind of rough data, but I really appreciate, you know, all your work. And people can look up your research. You can just do PubMed or NIH or anything else and find their research. It's fantastic. It's easy to understand. Share it with your providers and clinicians. Thank you all so very much for taking the time to do this. It's just makes such a huge difference. Crystal, did you want to say anything?
I just wanted to say thank you to folks that were able to be here today. And when this is up and hosted, please feel free to share with your people, because the more folks that we have out there with some baselines of understanding, the better. So thank you for being here.